blood pressure started trending down. And you do kind of do this like nurse thing, right? Where you're like, oh, let me check the other arm just to see. And the other arm was a lot higher. Right. But the patient was also kind of looking still oriented, slightly more lethargic, like minuscule, barely perceivable amount of lethargy in this patient. But we had been getting good blood pressures on this arm for a while. And now we're kind of starting to see like this trend down. And I went and I talked to the resident at the time. So the attending doctor wasn't even there. Doctors will ask you, what are their vital signs? And so I'm explaining to the resident the blood pressure is kind of starting to trend down. Like we've been taking it on this arm. I'm not really concerned that the blood pressure is inaccurate because we've been getting accurate results, right? And so the resident called the attending who didn't come and actually look at this patient. And the response from the attending was, well, did you take it on another extremity? I'm like, yes, I took it on the other arm. And it's still like not really acceptable. It's a little higher, but we're still seeing like this trend down. And they responded to me, take it on the leg. No. No, I need you to come and look at this patient. I need blood work. We need new blood work. And I hate to say it, but like this particular physician was a little more laissez-faire. I think that's the word I'm going to use. A little more like, it's fine, more reactive rather than proactive. And I was just like, no, I'm not going to take it on the leg. We've been taking it on the same arm. It's like
we have
you
data.
need. Yes, right? But how can you tell me that all of these blood pressures previously are acceptable, but now that it's low and now that I'm calling you because I feel like there's an intervention, you're going to tell me just to take it on the leg? I did it just because I am, slight pecking order. I'm like, it was okay. And he's like, well, we're going to use that one. And I'm like, no, we're not. You need to come and you need to look at this patient because there are slight, cognitive changes. And
Sure.
even though it's still okay, like we're seeing this downtrend, ended up coming, right, and actually looking at the patient and was like, you know what, you're right. Let's order some blood work, all of these things. And the patient actually ended up going septic. Yeah. So the big thing with this story is I want to really encourage you to trust your gut. No part of the team is inherently better than the other. As a nurse, though, you are the one who is with the patient and you are the one who is seeing the patient and really, really looking at these trends and kind of this whole idea of what we've been talking about is vital signs are great and it's good to know when they're normal, but seeing these kind of subtle changes and changes in trends and changes in other aspects of your assessment really, really make the difference of like being able to catch things early. And so I don't really know what would have happened to this patient if I just hadn't trusted my gut and been like, nope, something is really wrong.